Hi, my name is Gaba, a research associate with Brandeis University at the Institute of Global Health and Development in the Heller School for Social Policy and Management. Today, I'm presenting some of the results from the ABCM exercises in Tanzania and Uganda. These were the first two countries to complete these analyses and were subsequently followed by Mozambique, Kenya, and Namibia. Other studies are currently planned for Lesotho, Eswatini, Botswana, and India. I'm representing only the result from the first two countries in order to keep this presentation concise. I would note that these first two analyses were funded by the USAID under the HP Plus project in Tanzania and the UHSS project in Uganda. I'll start today's presentation with the key research questions. Second, I'll discuss the findings, then we'll wrap up with some policy implications for consideration and the next steps. The full presentations and reports for each country goes into a bit more detail about the results and are available for review. But for the purpose of this YouTube video, we have limited the presentation to a short summary of findings from both countries. The main objective of the ABCM is to generate cost information to provide HIV and other health services and use the data to effectively allocate resources, improve monitoring efforts, and increase efficiency and quality of services. Regarding country and regional leadership, the regional network chaired by Tanzania established countries that have done or are contemplating doing ABCM. Kenya plans to expand all health services and do this at a subnational level. In Uganda, a series of workshops are being held to share and discuss data findings and implications with all participants, and Makerere University has made this a part of their curriculum. PEPFAR will also make this an integral part to sustainability planning, reconfiguring its investment and transparency in discussions with governments. Now, let's take a look at the research questions. The research questions we address in both Tanzania and Uganda include: what are the actual unit costs of providing select HIV services? What are the main cost drivers of these unit costs? How much variation is there in the unit cost, and can this be explained by either the facility type or the patient's characteristics? Are there ways to make this service delivery and interventions more efficient? And how can we make this process of data collection become more routine? Now, let's take a look at the findings. The following slides discuss the findings of the first phase of the ABCM analysis. The results to be presented today will include the cost collected at the facility level as well as at the community level. We will also discuss the result that came out of the client interviews and an analysis of the above site cost. At the facility level, we see a number of common takeaways in both countries. For ART clients, for example, ARVs and the lab costs were the most expensive cost drivers. We were also able to observe that clinical contact times were much shorter than optimal and waiting times were much longer than ideal. We also noted in both countries that the personnel costs tended to be quite low. Fourth, we noted quite high levels of absenteeism among the service providers in both countries, which contributes to the inefficient delivery of services. Finally, we noted that there were significant cross-subsidization of the non-HIV programs by the HIV programs. The analysis of the community cost indicated that the community-based care and treatment services tended to range from about $10 per year to $20 per year in Tanzania and $4 to $24 in Uganda. As for the client cost, we noted that there were significant costs associated with the lost income and transport to health facilities, but out-of-pocket spending for health services tended to be quite low. Finally, as for the above site costs, we noted that these tended to be highest of all the cost categories. However, the analysis was not able to clearly identify those cost elements that were most driving these expenditures. It will be important to look into this cost in more detail to better understand what investments are essential and how we may focus on future cost reductions. This figure shows the clinical time required for different HIV interventions. The average time spent at a facility varied from different services, ranging from as low as 20 minutes for a PrEP visit in Tanzania to 148 minutes for a VMMC visit in Uganda. In addition, the waiting time varied quite significantly, from only 25% of time for PrEP in Tanzania to as high as 59% for ART unstable patients in Tanzania. Overall, patients spent about 40% of their time waiting in Tanzania and 35% of their time waiting in Uganda. It should be noted, however, that this varies significantly from one facility to the next and from one client to the next. One of the most useful tools developed as part of this costing exercise is a process map. A process map is used to observe steps that are taken in caring for a client. We can compare, for example, what steps should be taken in treating a patient in need of care and treatment, and compare this with what is actually being observed. This is useful for identifying if steps are being skipped. The process maps also collect the amount of time that are spent with patients, and again, we can see if a clinician is spending an optimal amount of time with the patient or if they are just rushing through the processes. We can also identify if certain facilities are doing very well in terms of following the optimal care and treatment cascade, while also identifying if there are potential inefficiencies in other facilities. Within a facility, for example, we see that sometimes services are delivered differently, even from patient to patient. In this example, for instance, you see that only 35% of patients had their vitals taken, and only 59% of the unstable patients received any form of counseling. In other words, the care process is not being consistently delivered. In terms of time taken, we can also see that there's a significant difference between the ideal time spent and the actual time spent. For example, the colored circles indicate the results from our key informant interviews, which indicated that counseling should ideally take 20 minutes with unstable patients. In this case, however, we notice that only 8 minutes is being spent on these patients. We also see that consultation should ideally take 25 minutes, but in this case, we observe that only 6 minutes is being used for consultation. So by looking at the colors associated with each step, we can also identify the cadre of people who are delivering or not delivering at each step in the process. The following figure shows the unit cost per visit in USD for the ABCM analysis done in Tanzania and Uganda. There are several similarities across both countries. First, consumables represent the largest unit cost, followed by the personnel and then the indirect cost, which includes the overhead cost, equipment, and the value of the facility space. HIV testing is the least expensive intervention, ranging from $4 to $5 per visit that was costed in both countries. This was followed by PrEP, which was $7 to $11 per visit. PMT-CT tends to be higher in Tanzania at $24 than in Uganda, where it was $19 per visit. In Uganda, the ART cost per visit ranged from as low as $14 for the ART new patient to as high as $36 per visit for the stable ART clients. The cost of the antiretrovirals and the use of the multi-month transcripts in both countries influences the cost per visit. It should, however, be noted that these costs represent only the facility level cost and the consumables, and don't include the community level cost or the above site expenditures. The following figures show the annual cost of providing ART to a patient over a 1-year period in both Tanzania and Uganda, including the facility, community, commodities, laboratory, and various above site costs. As the figure shows, the cost is nearly identical across both countries, ranging from $237 per year in Tanzania to $239 per year in Uganda. Commodity costs represent the largest cost in both countries. The following figure shows the cost of HIV testing in both Tanzania and Uganda. The figure shows that the unit cost varies from $5.38 in Uganda to $8.29 in Tanzania. The largest cost incurred was for commodities, which is largely the HIV test kits. This is followed by the facility level cost. In Tanzania, it was possible to compare the cost of the community level testing with the facility level testing, with the community level testing being somewhat higher than the facility-based testing. Also worthy of note is that the $8.29 that we see for the cost of testing HIV in Tanzania represents a weighted average of the cost, because the test is either done at the community level or at the facility level and not both. This figure shows the cost per circumcision visit. In both countries, the cost was similar, at between $40 and $45 per client circumcised. The main cost drivers were the commodities, that's the circumcision kits, followed by program management and facility level cost. For some clients, there may have been as many as 3 visits per circumcision, that's a pre-circumcision visit, the circumcision visit itself, and a post-circumcision visit. Care and treatment support services at the community level include such activities as adherence counseling, peer support, loss to follow-up tracking, etc. We interviewed 7 PEPFAR implementing partners in Tanzania and 6 implementing partners in Uganda to assess their cost of providing community-level support services. To avoid double counting program management and non-service delivery expenditures, these were extracted from the unit cost. As a whole, we found that the unit cost of service delivery was $11.24 per person per year in Tanzania and $17.18 in Uganda. This slide shows the economic burden by wealth quintile. Economic burden in this case represents the cost of transport, lost income, and out-of-pocket expenditures relative to monthly household discretionary income. The first quintile represents those who are the poorest, while the fifth quintile are those who are the wealthiest. The downward sloping lines shows that the poorest generally incur greater costs relative to household discretionary income, while the wealthiest incur a relatively lower financial burden. This is an indication of the inequities and burdens incurred by the poorest in Tanzania and Uganda. The importance of these findings suggests that there may need be greater support provided to those who are poor in order to eliminate these financial burdens. This might include reducing transportation costs or providing subsidies to make sure that clients continue to make their medical appointments. So what are the implications of this analysis? There were several key findings that need to be addressed further in both Tanzania and Uganda. First, we have noticed several places where steps in the process map are being skipped, or where there isn't enough time spent on a particular step. Understanding the process maps is critical, and knowing how to respond to missed steps or inadequate time on a particular step may have a lot to say about the quality and effectiveness of the services provided. At this point, we don't know exactly why steps were skipped or inadequate time was spent, but this certainly is an area for more in-depth analysis. Second, while we can see opportunities for efficiency gains at the facility level, it is also important to focus on the above site cost. In many cases, these costs are significant and therefore should be an area for more detailed analysis. Are these expenditures critical, for example, or are there opportunities for cost savings by reducing investments in above site costs that are unnecessary? Third, the ABCM approach allows us to focus on issues of efficiency, including absenteeism of service providers and idle clinical capacity. By focusing on these issues, we can hopefully determine if wages currently provide adequate incentive for healthcare workers to show up every day. Fourth, we have noted that transportation and opportunity costs represent a significant burden to clients. Differentiated care should represent an opportunity to reduce the amount of time that clients are required to visit facilities. Finally, we have noted that donors like PEPFAR are not only buying HIV services, but are also producing other positive health benefits with their programs. So what comes next? We have now incorporated the facility level, the above site costs, and community level findings. This all constitutes what has been done under Phase 1. Phase 2 involves assuring that this process can be sustained by building capacity of stakeholders in Tanzania and Uganda regarding the importance of this data. There's also the need to repeat the data collection process in both countries. This will require determining which interventions should be costed again and which new health interventions need to be costed. Both Tanzania and Uganda focus only on HIV, but as ABCM has evolved, non-HIV interventions have been included in the costing. Thank you for watching this educational video on the results of the ABCM analysis in Tanzania and Uganda.